Welcome to yet another thrilling episode of FMGE High Yield Edition. Prepared to showcase your knowledge as we present you PYQs, each requiring a quick response of just 5 seconds. And hold on tight, because the incredible Dr. Pritesh will provide concise explanation for each question. Remember to share your score with us in the comment section at the end. Let's dive into the first question appearing on your screen now.
Question 1. A man came with complaints of recurrent discharge and pain due to lesions around the anus for 3 years. A diagnosis of fistula-in-ano is made. What is the gold standard investigation for this condition? Here are the options. A. Fistulogram. B. USG. C. CECT. D. MRI. And the correct answer is option D, MRI. Here's the explanation.
First investigation done in fistula-in-ano, and that's fistulogram. Fistula-in-ano, inject the dye, take x-ray, fistulogram. And what is the investigation of choice for diagnosis? Here it's the MRI.
Question 2. A diabetic patient developed DVT with a necrolytic migratory rash. What is the most likely diagnosis? Here are the options. A. Insulinoma. B. Gastronoma. C. Glucagonoma. D. VIPoma. And the correct answer is option C, glucagonoma. Here's the explanation.
Now see this typical dermatitis. This is necrolytic erythema migrans. And necrolytic erythema migrans is the most common symptom of glucagonoma. So this is what? Glucagonoma. What is the other name of glucagonoma? It is also known as hyperglycemic. There is hyperglycemia. Cutaneous syndrome. So it's also known as hyperglycemic. Why hyperglycemia? Because of increased release of glucagon. Cutaneous syndrome. Why? Because these patients have dermatitis. And what is the most common presentation or most common symptom? Necrolytic erythema migrans. Glucagonoma is also known as 4D syndrome. So what are the 4Ds? First, diabetes mellitus, there is dermatitis, there is deep venous thrombosis and depression. 4D syndrome. Out of these, what is the most common symptom or manifestation? It's known as necrolytic erythema migrans. Necrolytic erythema migrans. This is the most common symptom. Apart from this, patient is having diabetes, patient is having deep venous thrombosis, dermatitis, depression.
Question 3. A 6-year-old man presents to OPD with low backache. His PSA level are 100 nanograms per milliliter. Which of the following drug is indicated for treatment? Here are the options. A. Somatostatin. B. Telepressin. C. Goserelin. D. Testosterone. And the correct answer is option C, goserelin. Here's the explanation.
If the patient is having advanced malignancies like T3 and T4, the stages T3 and T4, in these cases, hormone therapy is preferred over radiotherapy. We discussed that prostate is under the influence of which hormone? Testosterone. So we are going for androgen ablation. So how we can go for androgen ablation? We can go for bilateral orchidectomy, or we can use LH-RH agonist. So for T3 and T4, the preferred strategy is what? It's the androgen ablation. This androgen ablation is preferred over palliative radiotherapy. It is preferred over palliative radiotherapy. How we go for androgen ablation? Bilateral orchidectomy plus flutamide. Okay. And if patient doesn't give the consent for orchidectomy, or what is the other alternative? We can go for medical orchidectomy with the help of LH-RH agonist and flutamide. Right? This is the famous question of AIIMS, that which LH-RH agonists are used. These are also used in CA breast. So one is goserelin and the second is leuprolide. So it's the goserelin and leuprolide, and this is the famous question of AIIMS. It was asked 4 to 5 times in AIIMS, that which of the following is or which of the following drug is recently FDA approved for advanced and metastatic carcinoma prostate, and that is goserelin. So recently FDA approved for advanced and metastatic carcinoma prostate. If you remember, there was one question in NEET super specialty that there are two new drugs approved for castration resistant metastatic carcinoma prostate. So what are the new drugs for castration resistant carcinoma prostate? You have to remember because this was asked in exam. First is cabazitaxel and second is sipuleucel T.
Question 4. A car driver was brought into the ANA following a RTA with complaints of breathlessness. On examination, his vitals are PR 112 per minute, BP 170ths, SpO2 to 90%, and there is extensive bruising on his chest. What is the management of this patient? Here are the options. A. Chest tube drainage. B. 24% oxygen. C. IPPV. D. Internal operative fixation of the fracture segments. And the correct answer is option C, IPPV. Here's the explanation.
First, there is paradoxical respiration. Second, there is voluntary splinting because of pain. And there is mechanically impaired chest wall movement. Mechanically impaired chest wall movement. Clear? And because of all these things, what's the problem? Yes, there is increased risk of respiratory failure. Right? So this is one of the factor. The patients of flail chest are also having pulmonary contusion. Right? So because of all these factors, there is increased risk of respiratory failure, and the patients are also having pulmonary contusion, which also increases the risk of respiratory failure. But all patients are not having respiratory failure. Now, how we are going to make the diagnosis? So we discussed in tension pneumothorax that flail chest and the diagnosis of tension pneumothorax is made clinically. So how we are going to make the diagnosis? It is diagnosed clinically. Clear? So how you are going to make the diagnosis? Observe the patient for number of respiratory cycles. So when you are observing the patients, and especially its respiratory cycle, the inspiration and expiration, during some time you are going to notice that there is paradoxical respiration. So what happens? The chest cavity moves out, but the isolated part of chest wall goes in, and chest cavity moves in, and that part of isolated chest wall goes out. And if you don't have patience, you want to diagnose it immediately. So you ask the patient to cough. Ask the patient to cough. So when patient is doing coughing, for coughing the chest wall goes in, but that isolated part of chest wall goes out because of positive pressure created inside the thorax. Clear? So ask the patient to cough, chest cavity moves in, but that isolated part of chest wall goes out. So this is how we make the diagnosis. Now coming to the treatment. Students are going to do this mistake in exam. In exam, the question is asked that what is the treatment of choice of flail chest? So if a patient is having only flail chest, there is no respiratory failure, in that case we give oxygen. So oxygen administration, the main component is adequate analgesia, generally by epidural analgesia, and we provide physiotherapy. That's it. If patient is having respiratory failure, then only we go for intermittent positive pressure ventilation. So see the management. So in flail chest, the management is oxygen administration. We provide adequate analgesia, and generally we provide this by epidural analgesia. So epidural analgesia and physiotherapy, right? But see, in exam, in option, oxygen administration and physiotherapy is generally not mentioned. They ask the question that what is the treatment of choice of flail chest? Adequate analgesia, and second, intermittent positive pressure ventilation. So the treatment of flail chest is adequate analgesia, and the treatment of choice for flail chest with respiratory failure is intermittent positive pressure ventilation. Okay.
Question 5. Which of the following tests would a surgeon advise first in a patient with a large thyroid swelling? Here are the options. A. Ultrasound of the neck. B. FNAC. C. Thyroid function tests. D. Radioiodine uptake. And the correct answer is option C, thyroid function tests. Here's the explanation.
What is the most common solitary thyroid nodule? You have seen these patients in OPD, and that is colloid goiter, followed by follicular adenoma. So most common solitary thyroid nodule, it is colloid goiter, followed by follicular adenoma. Follicular adenoma, right? Another important point. What's the first investigation done in the patients of solitary thyroid nodule? And you must be knowing, first investigation done, it's thyroid function test. So the first investigation done in solitary thyroid nodule, that is thyroid function test. You know what are the components of thyroid function test? T3, T4, TSH. Out of T3, T4, TSH, which one is most informative? And it is TSH, right? So here you can see the components are T3, T4, TSH.
Question 6. Identify the condition shown below. Here are the options. A. Strawberry stain. B. Erythema multiforme. C. Erythema subitum. D. Port wine stain. And the correct answer is option D, port wine stain. Here's the explanation.
So see this first condition, you can see it's a newborn baby, and this baby is having anomaly in the face. Clear? So can you see? And it's the area supplied by which nerve? The fifth cranial nerve, and that is trigeminal nerve. So what is the name of this condition? This condition is port wine stain. Now 2-3 important points. It's a stain, and you know you cannot remove a stain. So stain is going to persist. So this port wine stain, can you see? It is present at the time of birth. It grows along with child, doesn't regress, and generally it is seen in the face. In which particular area? Area supplied by trigeminal nerve or fifth cranial nerve. Clear? So see the important points. It's port wine stain, and you know stain persist. Clear? So first important point, it's present at birth. Clear? It grows along with child. Grows along with child. It don't regress. It doesn't regress. Clear? So doesn't regress means it's permanent, and generally involving face. In face, which particular area? Area supplied by fifth cranial nerve or trigeminal nerve.
Question 7. A 6-month child presented with the following presentation. What is the management protocol? Here are the options. A. Indication of surgery if not resolved by 2 years. B. Surgery after 5 years. C. Immediate surgery. D. Herniaplasty. And the correct answer is option B, surgery after 5 years. Here's the explanation.
Now we are going to discuss umbilical hernia. So what is the definition of umbilical hernia? It's the hernia occurring directly via umbilicus. And paraumbilical hernia, hernia within 2 cm of umbilicus. Here you can see the picture of umbilical hernia. This is an infant and this is an adult patient. So an adult patient and an infant, and here you can see herniation directly via umbilicus. In infants it is congenital, and in adults it is acquired. So see what are the differences. If you're talking about the umbilical hernia in infants, this is congenital, and generally it is more common in Africans. So it's more common in Africans. And what is the good thing? That there is spontaneous resolution by 2 years of age. So this is going to close spontaneously by 2 years of age. So there is spontaneous closure. You have to remember the age, and this spontaneous closure occurs by 2 years. It occurs by 2 years of age. What happens in adults? In adults, it is acquired. And in which cases you are going to find the umbilical hernia? Any patient in whom there is increased intra-abdominal pressure leading to stretching of umbilicus. So you will find the cases of umbilical hernia mainly in the females. Why? Because these are multipara females. Especially which females? Multipara females because of pregnancy. And patients who are suffering from ascites. Which patients? What's the most common cause of ascites? Cirrhosis. So patients of cirrhosis which are having ascites, because of that also there is stretching. In adults, it is acquired. Clear? And what are the risk factors? It is more common in females, and risk factors are any condition in which there is increased intra-abdominal pressure. So in which conditions? Like we have seen pregnancy, multipara patients especially, and patients who are having ascites. What's the cause? Because of cirrhosis. And even in patients of obesity also. What? In obese patients also we are going to find the umbilical hernia. What is the good thing? Since there is stretching of umbilicus, so what happens over a period of time, the size of defect is going to enlarge. And since over a period of time there is stretching and the size of defect is going to enlarge, that's why the risk of complications are rare. So whether it is in infants or in adults, the risk of complications, so complications are rare. So it's rare. Okay. Now see, in all patients surgery is not required. So what are the indications of surgery in patients of umbilical hernia? Indications of surgery in patients of umbilical hernia. Okay. So generally we are supposed to wait for 5 years, maximum 5 years. We discussed that by 2 years usually spontaneous closure occurs. So maximum we are going to wait for 5 years. Even after 5 years, if there is no closure, we have to go for the repair. So if it persists beyond 5 years, so hernia persists beyond 5 years. Second, if the patient is having symptoms or if there is strangulation, so there is complications like strangulation. So symptomatic patient, if there is strangulation or if the size of defect it's more than 2 centimeter. So whenever the size it's more than 2 centimeter, and you are going to notice that there is progressive enlargement of hernia over a period of 1 to 2 years. So whenever there is progressive enlargement after 1 to 2 years, progressive enlargement after 1 to 2 years. Clear? Okay. And what about adults? Adult patients who are symptomatic and the adult patients who are going to develop any complications. In those cases, we have to perform the surgery.
Question 8. Correct procedure of inserting nasogastric tube is? Here are the options. A. Supine with neck extended. B. Sitting with neck flexed. C. Sitting with neck extended. D. None of the above. And the correct answer is option B. Sitting with neck flexed. Here's the explanation.
Nasogastric tube. First question which was asked many times related to this tube, that what is the ideal position of insertion? If a patient is conscious, you have seen in emergency how we are going to insert. If a patient is conscious, the ideal position is sitting and neck flexed. And if patient is comatose, what is the ideal position? Supine and neck flexed. So first important point, what's the ideal position for insertion of Ryle's tube? In conscious patient, it is sitting position with neck flexed. Okay. And what about comatose patient? Supine with neck flexed. So if patient is comatose, The ideal position is supine with neck flexed. Okay, so this is the ideal position for insertion of Ryle's tubes.
Question 13. A 47-year-old woman presents with a thyroid lesion which is found to be papillary carcinoma of thyroid. Which is the best treatment for this patient? Here are the options. A. Thyroid ablation using radioactive iodine. B. Total thyroidectomy. C. Observation. D. Hemithyroidectomy. And the correct answer is option B. Total thyroidectomy. Here's the explanation.
Now coming to the treatment. One thing you know about thyroid malignancy, that we have to perform total thyroidectomy. Apart from total thyroidectomy, there is involvement of level 6 lymph node or central group of lymph nodes. So we go for removal of enlarged central group of lymph nodes. If any lymph node is positive, in that case we go for ipsilateral MRND. So what's the treatment? For papillary carcinoma thyroid, we perform total thyroidectomy plus removal of enlarged central group of lymph nodes. Enlarged central group of lymph nodes plus minus ipsilateral MRND. MRND means modified radical neck dissection if any lymph node is positive. So this is how we manage papillary carcinoma thyroid.
Question 10. A 50-year-old male with a known case of the varicose veins in the lower limbs has developed itching and ulceration around the ankle and calf region for a few days. Venous ulcers of the lower limb usually develop in the area of the calf and ankle. Which ulcer is likely to develop in a long-standing chronic venous ulcer? Here are the options. A. Marjolins ulcer. B. Athos ulcer. C. Pressure sores. D. Necrotizing fasciitis. And the correct answer is option A. Marjolins ulcer. Here's the explanation.
Now see this picture and tell me what is the diagnosis. So can you see here the tumor is having outward growth towards surface. It means it is a type of squamous cell carcinoma. And what is the second clue in the picture? You can see that here there is scar. Can you see? There is presence of scar. So there is a malignancy which is arising from some old scar and which is squamous cell carcinoma. So what is this kind of ulcer? This is Marjolin's ulcer. So what is this? The diagnosis is Marjolin's ulcer. This is frequently asked in exam. And you know that Marjolin's ulcer is a low-grade squamous cell carcinoma. It is low-grade squamous cell carcinoma and it arises from long-standing scar or chronic benign ulcer. So it arises from long-standing scar or chronic benign ulcer. Chronic benign ulcer. Okay, so generally see from which areas or from which scars it is going to develop. So see here, this long standing scar, generally it is arising from burn scar. So Marjolin's ulcer is arising from burn scar. And chronic benign ulcer, what do you mean by chronic benign ulcer and in which ulcers this malignancy is seen? It is seen in long standing venous ulcer, if the patient is having chronic post-traumatic ulcer, or if there is radiation induced ulcer. So from these ulcers you will find that patient might develop what? Marjolin's ulcer. And if a patient is having chronic discharging osteomyelitic sinus, even chronic discharging osteomyelitic sinus also increase the risk of Marjolin's ulcer.
Question 11. Best treatment strategy for carcinoma anal canal. Here are the options. A. Chemoradiation. B. Surgery. C. Radiation. D. Chemotherapy. And the correct answer is option A. Chemoradiation. Here's the explanation.
Now coming to the treatment question was asked minimum 100 to 200 times. And what is the question? What is the treatment of choice for carcinoma anal canal? And it's the Nigro regimen, and that includes chemoradiation. So see, the treatment of carcinoma anal canal and the treatment of choice, it's Nigro regimen? Famous question. And what is this nigro regimen? This is chemoradiation. So in this, we give chemotherapy followed by radiation. Okay. So which chemotherapy agent? We give 5-fluorouracil plus mitomycin C. At some centers, at the place of mitomycin C, cisplatin is also given. So it is 5-fluorouracil plus mitomycin C followed by radiation or radiotherapy. So chemotherapy agent 5-fluorouracil plus mitomycin C followed by radiotherapy. When we give chemo radiation, you can't believe tumor disappears. So generally after 4 to 6 weeks, we go for check biopsy. And on check biopsy, tumor disappears. Imagine if there is persistent tumor persists on the check biopsy. So after chemo radiation, if there is no response and tumor still persists, in that case, we go for abdominoperineal resection, which is also known as Miles procedure. So this is how we manage carcinoma anal canal.
Question 12. Most common type of rodent ulcer is. Here are the options. A. Superficial. B. Cystic. C. Nodular. D. Pigmented. And the correct answer is option C. Nodular. Here's the explanation.
So in pathology, this question is also asked that what are the types of vessel cell carcinoma? There are 4 types: nodular, pigmented, cystic and superficial. Nodular, pigmented, cystic and superficial. Clear? So which one is the most common type? The most common type is nodular. And we discussed what is the classical feature of nodular variety. There is presence of pearly white nodules in the periphery, dilated vessels over the surface, that is known as telangiectatic vessels, and there is central depression with umbilication.
Question 13. Correct description about Paget's disease of breast. Here are the options. A. Eczema of skin of nipple. B. Eczema of skin of areola. C. Mastitis carcinomatosis. D. Atrophoxerous carcinoma. And the correct answer is option A. Eczema of skin of nipple. Here's the explanation.
Now see this image. This is a potential image based question. What you can see here in the breast, you can see this is the nipple, and you can see that there is chronic eczematous lesion. There is eczematous lesion or eruption of nipple. So what is the name of this condition? This is Paget's disease of nipple. So the name of this condition is Paget's disease of nipple. Clear? And what we find in this condition, there is chronic eczematous lesion or eruption of nipple. So here you can see there is chronic eczematous lesion. Okay, what is the significance of this Paget's disease of nipple? That it is associated with underlying malignancy. Sometimes there is ductal carcinoma in situ, and sometimes there is invasive ductal cancer.
Question 14. False regarding deep second-degree burns. Here are the options. A. Heal by scar deposition. B. Painless. C. Damage to deeper dermis. D. Less blanching. And the correct answer is option D. Less blanching. Here's the explanation.
Second-degree burn. And we discussed what is the name of second-degree burn. It is also known as partial thickness burn. Partial thickness burn. Clear? This is further divided into superficial partial thickness and deep partial thickness. So see the types. It is further divided into superficial partial thickness burn and deep partial thickness burn. Clear? So in superficial partial thickness burn, we discussed that it's going to involve what? Epidermis plus papillary dermis. Papillary dermis. Okay, how you are going to remember? By the example, suppose sometimes we are making tea or coffee and there is spillage of hot tea, hot coffee, hot milk or hot water, and whenever there is spillage of hot tea, hot milk, hot water, what happens? Sometimes you are going to notice that there is presence of blisters, It is painful or painless? It is painful. So partial thickness burn, superficial partial thickness burn, it is painful. There is presence of blisters. It heals with scarring or without scarring? Without scarring. And in how many days? 7 to 14 days. Clear? So the important points related to superficial partial thickness burn. So it's painful. There is presence of blisters and healing occurs without scarring. Healing occurs without scarring within 7 to 14 days. Okay, we have this kind of burn. In deep partial thickness burn, there is involvement of epidermis plus reticular dermis, right? And if you have seen this kind of burn, you will notice that whatever the area which is burned, which is deep partial, having deep partial thickness burn, what that area appears mottled, and there are whitish pinkish areas. There are no blisters, there is no pain, but pinprick sensation is preserved. And in this case, healing occurs with scarring. So in deep partial thickness burn, there is involvement of epidermis plus reticular dermis. Reticular dermis appearance, it's mottled. Clear? So it is having whitish and pinkish areas. So there is whitish and there are whitish and pinkish areas. There are no blisters, no pain, but pinprick sensation is preserved. Pinprick sensation. So pinprick sensation, it's preserved. Clear? And here healing occurs with scarring and it takes 3 to 9 weeks. So here healing occurs with scarring, and how much time? Generally 3 to 9 weeks.
Question 15. Most common site of peripheral aneurysm. Here are the options. A. Brachial artery. B. Popliteal artery. C. Radial artery. D. Femoral artery. And the correct answer is option B. Popliteal artery. Here's the explanation.
Now see the important one-liner questions which are asked in relation to aneurysm. First question, what's the most common site of aneurysm? It's the circle of Willis. So the most common site is circle of Willis. Now see the second question, what is the most common site of extracranial aneurysm? And the most common site of extracranial aneurysm is what? Aorta. Which part of aorta? Is the infrarenal aorta. So we are going to discuss the one-liners. First question, that what's the most common site of aneurysm? And the most common site of aneurysm, it's the circle of Willis. Circle of Willis. Very important. Second, what's the most common site of extracranial aneurysm? Okay, what? Extracranial aneurysm. And this is what? Infrarenal aorta. It's the infrarenal aorta. Okay. After infrarenal aorta, what is the second most common site? Yes, it is iliac artery. Iliac artery. After iliac artery, it's the popliteal artery. And after popliteal, it's femoral. Okay. So what's the most common site of extracranial aneurysm? Infrarenal aorta, followed by iliac artery, followed by popliteal artery, followed by femoral artery. Okay. So how to remember? The mnemonic is AIPF. So it's aorta, followed by iliac artery, followed by popliteal artery, followed by femoral artery. So how to remember? All India Police Force. Aorta, iliac artery, popliteal artery, femoral artery. Okay. In this statement, there is another question which is hidden, and this was asked many times in NEET PG. What's that question? Can you see? What is the most common site of peripheral arterial aneurysm? So if you see peripheral arterial aneurysm, so that is what? Popliteal. So another question, most common site of peripheral arterial aneurysm. Peripheral arterial aneurysm. Clear? And it's the popliteal artery. This is popliteal. Okay. Now another question, what is the most common site of splanchnic arterial aneurysm? What? Most common site of splanchnic arterial aneurysm, and that is what? Splenic artery. So it's the splenic artery. Splanchnic arterial aneurysm, so that is splenic artery. Okay, after that there is a term known as mycotic aneurysm, which is seen in infectious condition.
Thank you for joining us on this journey. We hope this series plays an important role in your revision for the upcoming July FMGE. Tune in for the part 2 of Surgery FMG Recall Rush tomorrow. Show us some love by hitting that thumbs up. Consider subscribing if you're new, as we come up with interesting ways to educate our dreamers. See you in the next one. Cheers!